Okay, I'm here with Dr. Jorge Palacios, and we're going to talk about um, neurofeedback and opioid dependence assessment and treatment. There's a three-part series of webinars that we are doing together on this topic. So I just wanted to have you talk a little bit about the problem of opioid addictions, and then ask you some questions about the training and about the protocols and so on. So, can you just tell me a little bit about where do you want to start?
Well, there are different points, different parts. From we can start talking about this big, huge problem about related to opioids, and also about the way we can see the effects of this type of addiction. But we can start in the for the easiest part, that is the amount of people and the amount of deaths that are registered, not only in America but all over the world. Since the drugs, the legal drugs used by the physicians to treat pain, has been spread about the globe, have been used in the developed country. The amount of people that uses and later needs and later depends on the opioid drugs, as they were recognized and known, has grown in huge amounts. You can see in a reunion, in a social reunion with friends and with even relatives, that at least two, if not three, of the people that are in the meeting, and they are talking about, I have to. I was with this back pain, and I have to take this drug. It has a little bit of opioids, but it is from the physician that I received the prescription, and I am being taken care. And you have the doubt that if there is really a cure, that if they are really using the medicine, and if they are only in few very specific times when the pain is just a big pain.
Hmm.
And as soon as you are talking with many people, you can find that there are a lot of people that uses the opioids, and not in small amounts, but in the big amounts, and many people that really needs it because they cannot live without them, because they have not only the pain, sometimes is an awful pain, but also they have the dependence.
Right. It's hard to even turn on the news or the radio, TV, anything on the computer without hearing about how many deaths and all of these problems that are happening. Now, we were talking before, since around the 90s, there was
Hmm.
a neurofeedback protocol developed for working with alcohol and some drugs at that time,
Hmm.
that was
Hmm.
very famous, and that was successful for a time. And since then, lately, with this big epidemic, we haven't heard so much in this field about it. What do you say about that?
Well, yes, you're right. This is an interesting question. Well, let me tell you that this is, I am surprised um, what happened with, as I call it, the Peniston and Kulkowski revolution. Because after all the people in the neurofeedback and the biofeedback field knew about the conclusion of this study, that was the first control applied psychophysiological study, that was a big, where big news in those times because those were the days of the reports of one subject and the results with one patient, and the results with just one case, and that's all. And then you see a well-controlled, balanced, controlled study with different type of groups and a control group and an active control group and an experimental group, and several control groups with different type of conditions, and the results were pretty well documented. Well, it was not only a contribution, the fact that there could be research with pretty good methodology for the time in this field, but also the results by itself were really important. Well, I thought that there was going to be a big revolution, not
Hmm.
only because of the whole amount of news about it, the whole amount of noise that many people did, the whole amount of communications between specialists, but because many people will be trained in those uh, application as an school. And today I don't see the school, I don't see the faculty, I don't see the training, I don't see the regular seminars, I don't see anybody that is being trained.
Mm. And what would you say that the differences are between the type of protocol that was being used at that time and what is necessary for the types of drug problems there are now?
Well, first of all, the difference are just in well, in methodology, of course, and in technology, because we are talking about almost 20 years. Uh,
Is it that long? Oh my God.
yes, remember, Harry, you and I were in high school. So the time has passed.
Yes,
We have to accept that the
yes,
time has passed.
yes.
But the thing is that the difference are only in that part. But the type of methodology doesn't mean that the other process and the other type of treatment doesn't work.
Right.
They only use different type of methodology. As far as I remember, uh, the other type of protocol was developed only for alcoholism, and they were many tests for different type of drugs.
Hmm.
And when they try to test it in the hard drugs, like for example heroin or cocaine, they found differences in the results and differences in the effects of the treatment.
Hmm.
But that was related to the type of drug, not because the treatment has some defects. So many people concluded that the treatment was only for alcoholism, but I don't see it used for
Right.
alcoholism either.
Right.
So that was the difference between one and that. They were right. They were right. The methodology was different. The type of treatment was restricted for alcoholism, and opioids are very different type of drugs with different type of effects.
So in the
In
go ahead. I'm sorry.
No, no, no. In fact, we have to talk about in terms of effects not only of opioids, but other type of drugs, like for example, cannabinol,
Hmm.
that has certain type of effects similar to those effects of the opioids, and it can be treated only with the traditional treatment protocol.
Hmm.
So, as far as I know, the treatment protocol has been used, and it has to be used for alcoholism. It can be used with the modern machines of neurofeedback, and it can be improved.
Right.
But it haven't done anything.
So in this three-part webinar series, um, the first part, you are talking about the QEEG analysis basics.
Hmm.
So that's the
Basics.
one part I think that is different than what was available at that time, right?
Well, yes, this is the beginnings. Well, first of all, we have to talk about QEG. QEG is not new. It is not from the 21st century. QEG started in 69, 68, 69, in the early 70s,
Hmm.
and it was created by E. Roy John,
Hmm.
who was a big professor in neurophysiology, and also, well, he have, and I have to say this, great students. One of them was Bob Thatcher, which is one of the scientists that has continued with the legacy of E. Roy John, and he started with this type of machines and this type of the measurements, but these were measurements of the times, of the epoch, of the 80s, of maybe, well, 70s. In the 80s were other type of machines for QEG. They were restricted for clinical neurophysiology. They were called digital EEG and brain mapping, and they were considered for the detection and diagnostic of epilepsy. But the big group of scientists that continue developing QEEG for other purposes start working in big problems in the early 90s. Those big problems were approached with the methodology that we discussed in the past webinar.
Hmm.
This methodology was called um, the source localization. We have to find where the brain wave was created
Hmm.
and was generated.
Hmm.
But this is a pretty difficult thing to do
Hmm.
because when you do the brain mapping with the caps and we use 21 electrodes or maybe 32 or maybe 60 or maybe 80, well, you collect a great amount of data, but you can, with all those data, you cannot say where the brainwave was generated.
Hmm.
So scientists, like for example Pascual Marquis in Sweden, create solutions very, very transcendent. It was the purpose to use a different type of mathematical solutions to do the calculations in order to figure with mathematical precision the precise part of the brain where the wave was generated.
Hmm.
So, picking the brain waves with the caps, converting the brain waves in numbers, using these numbers to do certain type of calculations based in Laplacian calculations they, mainly Pascual Marquis, could identify the place where the brain wave was generated.
Mhm.
They call this the inverse solution.
Mhm.
We do know we do not know where the brainwave was generated, but we receive different type of information that is considered different type of echoes
Mhm.
of the generated. So with this information, we are going to do the calculations, three-dimensional calculations, to find out and reduce the place where these brainwaves were generated and to see the original place. This was called the localization of the source using the inverse solution. It is called inverse because we do not know where it was, but we know where it reached. So from the place where it reached, we are going to narrow the search until we found the place where it was created or
Right.
generated, and that's the way we can identify where is the normal wave generated,
Mhm.
or if it is not a normal wave, where is it generated, and if it is the proper place.
So is this how you part of how you are able to be more specific to the training, the location that you're going to train, and what you're trying to increase or decrease in the brain?
Yes, that's the main point.
Hmm.
We call when we have in neurofeedback, when we found the place, let's say in this way, we call it ROI, region of interest.
Hmm.
This ROI is going to be used for the machine to do the feedback of the brainwaves
Hmm.
in order to do the reorganization of the voltage of the different waves in the EEG spectrum. That's what we do in neurofeedback mainly,
Right.
to redistribute the voltage of the EEG spectrum.
Right. So in the part one, you're going into the QEEG analysis and the basics and explaining in more detail what you were just talking about. And then after
Mhm.
that, in the second part, then you were going to be talking about, is it the cocaine and heroin?
Yeah, we are going to say only two things. First of all, this is the brain mapping of a brain that is inside the normal range, the
Hmm.
health range.
Hmm.
This is how it looks. And then we are going to say this is how it looks with an opioid user, with cocaine user, with heroin user.
So that's like the commercial that says this is your brain and this is your brain on drugs, with
More or less,
but
with,
but it with real.
but with real data.
So we're not gonna be using an egg, a frying pan. We're gonna be using the QEG technology.
We are going to use the QE. We're going to use real science in this case to do this type of comparison. Then we are going to do to talk about the basics of the treatment.
Okay.
And we're going to talk about the brain lesions that the cocaine and heroin causes. We are going to talk about other type of damage that does in the body, in the human body, and in the health by consequence. And then we are going to talk about the different type of procedures in these cases, um, because of course it is not more complicated or harder. I do believe that any type of addiction is hard to manage. It
Okay.
doesn't matter that it is ludopathy, it is addiction to the internet, addiction to the alcohol, or to marijuana, or to cocaine.
Mhm.
Addiction is hard to broke. Addiction is hard to
Mhm.
treat, no matter the type.
Mhm.
But in this case, we are treating with drugs that do harm the health and causes big brain lesions in an important part of the brain.
Right.
The commercial doesn't say this, and it is that cocaine and heroin generate big lesions in the prefrontal cortex.
Okay. And then part three, you were talking about fentanyl, right?
Fentanyl, yeah,
Right.
which is much more uh, um, big problem because it is not legal. It is not. It hasn't do anything with health. It is not controlled by any good laboratory. The laboratories are not, mostly laboratories are improvised. They are not. This is not a medicinal drug, which is another
Mhm.
problem, and it causes brain lesions, big brain lesions, in a very short period of time.
Mhm.
So the effects are bigger and in a short time, which is more serious. It causes bigger the amount of deaths.
Right.
But I was talking about the prefrontal cortex,
Right.
which is important in these cases because this is the place where the self control resides.
Right.
This is the place of the organization, of the anticipation, of the organization of behavior,
Mhm.
the self control of the different types of needs, of emotions, of behaviors, and related to many aspects. I will say all the aspects of our life, including the use of drugs.
Mhm.
So if these patients, if these people has the need, which comes from other part from the brain,
Mhm.
and they cannot stop or control or manage
Mhm.
this type of need, well, this is the field with the fertility field of addiction.
Right.
And the thing is that since marijuana and cocaine and heroin, or I say cannabinol, heroin, and cocaine are doing big additions in this zone of the brain
Mhm.
in a short period of time, well, this is why the use of all these substances become a serious trouble, a serious health issue in a few times.
Okay.
So we can, with all this technology, found the lesions, found the source with the inverse solutions, found the source of the slow waves, which are markers of lesion, found the source of alpha waves, which play an important role in the treatment, from beta waves, beta 1 waves mainly, that found another important part of the treatment, from SMR brain waves that play another part important of the treatment, and with all that together, we can create different models of intervention for this type of patients.
Okay. So that gives us some information, more information than I thought we would be able to get right now.
Yes.
But
Uh-huh.
it'll give people, I think, a good idea of what to expect to learn in the 3-part webinar series.
Well, maybe if they saw this interview, they don't need to see the webinar.
No, no, there's a lot more. There's a lot more. So
Of course, there's a
each
lot more because we have an hour and a half
hour and a
in
half for
each
each one. So
in
that's
each webinar.
yeah.
Yeah,
So that's
yeah,
a good amount of time and a lot more information
a lot of more
that people will
information
get,
there.
and they'll also be able to learn more about like what the next steps would be to be able to integrate this kind of therapy into work that they do.
Yeah, and the big need of practitioners
Right.
because they're in America and also here in Mexico and in Latin America, and I do believe that in many places in the world we need a lot of practitioners that uses traditional neurofeedback as they call it today and QEEG biofeedback to treat this huge health problem. And to continue reading to the numbers of the all the societies and world and the WHO World Health Organization and all that. Well, those are important numbers, but we have in the real life, in the field, with the patient, practitioners,
Right. All right. Well, we're gonna do our part to try to help more practitioners be available.
and to convince them to get trained.
Yes. Yes.
Okay,
Okay. Thank you. So we look
thank you,
forward to
Harry.
hopefully seeing lots of people in the webinar.
Okay,
All right.
thank you.
All
Bye.
right. Bye.